Welcome, everybody. Now, what percentage of Canadian, now, is everybody, write this down, everybody think, good for you. What percentage of Canadians are overweight?
70%.
70%. Very good. He's in the lead.
Yeah.
All right. What percentage of people who stop, say, on journal or Ozempic regain 2/3 of the weight?
Tell me that.
80%. Yeah. Turns out to be 70%.
Tell me that.
Well, so,
I'm on something.
well, I'm just saying is that,
That's why I brought.
and the best trial to put diabetes into remission is called the direct or the broad trial. He's going to show you some stuff about this here. And so if you lose 20 to 30 pounds, you can put diabetes into remission in about 8 to 9 out of 10 people. Success 5 years later is
13%.
holy shit. Most people regain most of the weight. The best trial that shows diet and lifestyle changes. How much weight do people think they lost?
I am like I lost 100.
Okay. And you kept it
Wow,
off?
amazing.
Right. Put her in the lead.
Yeah.
The diet and lifestyle, well, you're going to learn more about this, but basically diet and lifestyle changes for the vast majority. If you can get 10 pounds, that's fantastic. Okay? But 10 pounds is not enough. So what I did in the start of the pandemic, I put myself on those benefits, and my highest weight was about 185. My lowest weight is around 160. This morning I'm 167. I'm going down fighting on all cylinders. I had diabetes for a period of time, and so I put into remission, but I go ups and downs about this. It's sort of like the Toronto Maple Leafs or any sports franchise. You have your ups and downs. I think
It always go down.
Many ups, many downs, big downs.
that there's always tomorrow.
Yeah.
And you begin.
There's always next season.
What I find about sports franchises is that they're always trying to get better. What I find about most human beings is, I'll do this next time. There is no next time, actually. I'm 66 years of life, and if I look at insurance companies, I'm supposed to pay at 84. Okay, so if you make it to 65, you have about 20 years of life left on average. 10 years good, 10 years bad. Yeah. Is that? But those are the averages. You know, we all could beat the average. We all think we'll be special. So what I'm thinking right now is my last 20 years of life. I hope it's more. Don't know. I'm going down firing in all cylinders. And and these guys are going to try to help you fire in all cylinders. Please make this one of your biggest priorities. And they're going to show you a toolbox. And people say, I'm only going to do lifestyle changes. That's fine, but you're denying yourself of great opportunities. And to me, it's a blend of both worlds. And I'm thinking for myself, I have Ozempic in my back pocket and my journal. It's like a spare tire. It's, it's like here. But what worries me about this, we can lose muscle mass. We tend to lose. So we have and who's lifting heavy weights? A little bit is you're losing half your muscle mass. You've got to lift heavy weights. I'm sorry. You what do you peak? Somewhere around 25, and then you start to lose. And so you got to go down fighting. We just did the CN Tower. We had some fun. Now I got some good news and bad news. The good news, these guys are passing me. The bad news, I couldn't do that before. But I'm going down fighting, and I'm trying to, and you guys have some fun doing it, trying new things. Anybody want to? Maybe we'll do the stairs afterwards. Maybe not. I don't know. But I'm gonna let you guys. I got to finish off the clinic. People are mad at me for being late all the time. But that's okay. We're not okay. I don't know. But listen, thank you for all being here. Lots to learn, and just try different things. One of the things I found really helpful to me is that when my son lost about 30, 40 pounds, you hired a personal trainer that was helpful. I said, if you can do it, I can do it. And Ozempic was helpful, but I'm really committing 7 to 14 hours of serious activity. I hope to play squash tomorrow morning if someone comes out. I have 2 squash games on Saturday, 1 on Sunday. I'm going to do some weightlifting. I'm hockey tomorrow night. Now, I am the best hockey player for the other team. We're ranked 1 to 10, 10 being terrible. I'm at 10 minus. So I'm going to let you guys take over, and I'm going to I come join you a little bit. I'm looking forward to the food. I only had a salad so far today and coffee. And so right now I do this time restricted eating, and I find that to be helpful. So you have to try different things. And I never felt more energized most of the time by this time restricted eating. I usually like to exercise more, but no one wanted to play squash this morning. So I slept in.
Fantastic. Thank you so much. Perfect. We're getting started. We have lots to talk over. Please pause, stop me, ask questions. We'll make this a discussion. Some facts about obesity. This is taken from Obesity Canada. Anyone heard of Obesity Canada at all? It's an advocacy organization now. They're doing a lot of good work trying to bust some myths about weight, that it's not a behavior, that it's very biologically driven. And they're doing a good job. So they put some facts on the homepage. One, obesity is a chronic disease. In fact, anyone heard of the WHO? I think it was on the news this morning or yesterday. They put a guideline about using GLP-1 medications, weight loss medications, etc. Second one, very driven by biology. Environmental influence, but it's very driven by biology. And more than we think, and more than we have thought in the last 30 years, I would say. The health effects, we know, we don't want to talk about that much. It is treatable. And the last and most important one is that bias stigma is a huge effect in the journey of trying to keep the weight off. And I'm sure everyone has heard that movies, media, if you put it, search up obesity on Google, what kind of images you see. We all know about that. And that's harmful. And it's everywhere. In fact, it's in healthcare settings, right? So we have 64% of adults living with obesity have experienced some kind of weight bias in their lifetime. I think that number is quite low. If you want to talk about lifetime, it's probably a bit higher. In the media, it's everywhere. Okay. This is the toolbox Dr. Curnew was talking about, that we want to take this mentality that we want to use every single tool in the toolbox, anything that applies from intermittent fasting, this, that, the other, anything that is safe that we can do, plus medication, plus behavioral therapy, psychological tools, bariatric surgery, this, that, the other. We just want to throw the kitchen sink at it because it's a really tough thing to fight biology. And I'm sure you guys know, doing this with willpower over time, as Dr. Curnew just said, the success rates are a little bit abysmal. And it's not because of lack of discipline or this or that, it's just biology. It's very difficult.
So it's
And
not,
yeah.
not has a lot to do with psychology.
It does, but it's a bunch of things. So the cause of obesity is not just one thing. In fact, something we say is our genes haven't changed. How come we haven't had obesity 100 years ago? The environment has. So it's like that saying where you have the genes, but in an environment, you get that effect. It's like, why is cancer more often? We have the genes. As you get older, you have mutations, your genes change. Because you're older, because of the more smoking, pollution, this, that, the other, you get a disease. So it's the genes plus environment. That's where you get the bad combination. So there's a toolbox. Anyone know how obesity is defined at all? What does that even mean? So traditionally, there's something called BMI. I think most people have heard of BMI. That's body mass index. The problem with it is it's on a homogeneous group of people. It's not based on everybody. It's not based on South Asians. It's not based on the South Americans. It's based on Europeans mainly. The typical cutoff for obesity that insurance uses right now, and widely cited in the statistics, is 30. If your body mass index is 30, that's your mass divided by your height squared, then you have obesity. But you can have BMI of 27 and have obesity-related complications. And that's why they're trying to change the definition now, that is, don't follow the BMI. It's kind of frustrating when we fill out insurance forms for GLP-1s and they ask about just BMI, or they ask about what diets has the person tried in the past. They're not supposed to try diets. You have to have everything, not just this, then that. So we're going to talk a little bit about that. So the Lancet is a very reputable source, it's a journal. They put a few people together, all the experts, and they came up with this new definition of obesity that don't use BMI because it's not a direct measure of fat. Where the fat is important. Fat under the cheeks and your arms, that's aesthetics. It doesn't cause disease. You can be in a bigger body, be healthy. And that's a reality here. There's also this staging system of obesity where they classify it based on the effect and not just how big you are. Is it affecting metabolic processes? Is it affecting mental health? Is it affecting function? That's the definition, really, that's used. And this is an interesting slide. We're going to pause here. So you can have a BMI of 28.8, technically it's not clinical obesity, but you have old diagnosis is overweight, new diagnosis is no obesity. Why? It's because you have no functional impairments, metabolic health is good, at least for now, right? That's the idea here. BMI doesn't tell you the whole story. So what does tell the whole story is something called visceral fat. Who's heard of visceral fat before? Few people. You know about the belly, that's pretty much what it is. It doesn't always correlate with visceral fat. It means fat in and around organs. That's a toxic fat. That's the one we're going to reduce. Unfortunately, there's no crunches. I think you would know this. There's no way to spot reduce fat. I wish there was. Some evidence that some kind of exercises can help a little bit, but mainly it's through weight loss. It's through calorie deficit. I wish there was. So how do we tell how much visceral fat we have? You can do an MRI, X-ray, but the best one is waist circumference. In fact, when you want to measure your weight loss, don't just look at the scale, measure this. In fact, the first thing you notice sometimes is that the pants are getting smaller as opposed to the scale. The scale goes up and down. You have fluctuations all over the place. So where you store it matters. There's a picture of where the fat is not supposed to be, right? It's in the wrong place. You've seen sumo wrestlers, the big BMIs, but they have no impairments. So part of that is genetics, part of it is activity. They're very, very active. They have a lot of muscle underneath the protection. So part of that protects them from the complication of obesity. They don't have prediabetes, they don't have diabetes. That's different. But the rest of us is a different story. Putting fat here causes problems. Okay.
It's 102 centimeters.
Yeah, so that gives in inches. You want to do that? You want to Google that?
Yeah, I'll Google it.
I think every inch is 2.5 centimeters. Yeah, let us know in a bit. Okay. Yeah. But if you want to tell what is significant, anything more than 2 centimeters an inch of a waist circumference is significant. Anything less than that, more room for improvement, essentially. Okay, that's the scan I was talking about. Subcutaneous means under the skin. So all this white stuff is the fat. The rest is muscle in your organs. This is causing less disease, the one on the right, than the one to the left. See, it's all in there. It's in the liver. When we say fatty liver, that's what we're talking about.
So how would you tell that?
By the scan.
You'd have to have a scan.
Yes. And the poor man's guess of it is waist circumference in your belly.
So
I'm not gonna poke it.
okay. One thing is that pretty obvious.
Yeah, oh yeah, you can tell it.
The thing is that, like, so I'm not sure you can show, I have too much fat, not enough muscle. And I'm working really hard at it. And so, you have to keep your weight down, and you have to build muscle. And when you start yesterday, tomorrow, or whatever, it's like, we're not aging very well. Now, interesting, with our diet, life expectancy doubled in the last 150 years, right? Doubled. And we were eating organic back then. So modern medicine has made some great changes along the way. But our quality of life is getting to be like shit. We're getting, arthritis, we can't think, our joints are killing us. Our food supply is terrible. And so you have to decide what you're going to do. I'm a victim to a lot of this bad food, but I'm trying very hard. And so I think of, all this processed food. Oh, sorry. I think all this processed food is derivatives of cocaine. They affect dopamine. I love bread and pasta. I love chocolate. I love cheesecake. But if I was a cocaine addict, a little bit of cocaine, okay. So is it better just to avoid all these things or whatever? So I go through those struggles. And that's why I find that, we just realize we're human, and then we just get up and go. But what I find, what frustrates me is that there's not enough people that are really committing to this. Now, you guys are here, and you're going to work at it. And I want you to enjoy the journey. And if you want to join me on the hockey team, being a 10 minus player, fantastic. But you know, I'm going to enjoy the time I have left, learning new things, and I'm getting better at many aspects of this.
Now we're going to talk about why. So what I was talking about the WHO recently, we've known this for a long time, but when WHO puts something out, it makes the news, so people talk about it, that it's a real chronic disease and helps us to fight insurance a little bit better, essentially. That's the end of it. But also helps patients, because a lot of times we have these phrases that it's, and we hear it all the time, that it's my fault, that it's just lack of discipline. If only I could. But you're fighting biology. It's very difficult. This is a wonderful slide, and that's the definition that I borrowed from Dr. David Macklin. He's an obesity researcher in Toronto. So he describes obesity as a heritable because of its genetic propensity. So up to 70% is heritable. In fact, we have two parents that both have obesity. The chance of you having obesity is upward of 99%. If they've done twin studies, they've seen that what the association is quite remarkable. It's brain centered. The reason they say that is that most of weight is regulated in the brain, by the brain, your appetite system. And you've noticed many times the weight, you don't even have to count calories. The weight is always stable most of your life. Of course, there's life events and things change, but the body regulates itself. I think there's a book that says the body keeps the score. It's a little bit similar to that. It's very biologically driven. Environmentally influenced. So we're living in a world where calories are everywhere, like snacks, ultra processed foods, and that makes it difficult. That combination is not amazing. It's also relapsing, and what that means is many people have lost the same 20 pounds over and over again. In fact, there's a phrase that says the best way to gain 5 pounds is to lose 20 pounds because of that. So people without living with obesity, they have the different biology. It's not the same. They can lose the weight off and keep the weight off. And that's where the stigma that we have trouble comes from, is that if you just try harder, you can do it. I don't want to get repetitive, but it's a very important point. And it's treatable. The treatment is there. It's expensive, a little bit more affordable now. We know that. We're going to talk about cost very briefly. And this is the collision that happens. You have the human appetite system on the right, and you have this ultra processed, sugar, fat, salt filled, ultra portioned, ultra available to your door, DoorDash, etc. available. We have snacks everywhere, fairly affordable. And in this environment, this is what we have. They talked about this. We all know about the complications of obesity. We're not going to go over it. This just shows how the rates have gone higher over the years because of our environment. Now we're going to talk about treatments. Any questions so far at all? We're going to take a pause here before we talk about the main character of tonight's show, GLP-1s and other things. Any questions so far? Thoughts, comments? Feel free to pause me, okay? Okay. This is probably one of the most important slides. It talks about the pillars of obesity treatment. This diagram summarizes it nicely. The first pillar is, there's no first or second, but one of the first pillars is psychological therapy or behavioral therapy. They're used in tandem. The other one is pharmacotherapy. In plain language, that means medications. Okay, whether it's injectables, pill versions of them that they're being tried, they're not out yet, but they're very effective also. And bariatric surgery, which is the most effective thing that we have to date for most people. And you notice that diet and exercise is not one of the pillars. It's actually at the top. In other words, without those things, without those pillars, the house falls down. And so when we think about how to treat obesity, a lot of people think it's lifestyle first. If you fail that, then you go to bariatric surgery. Where actually is the other way around, in the sense that getting those therapies allows people to do those things, to make the lifestyle changes we all talk about, and then stay on it. Otherwise, it's very difficult. Now, it doesn't mean you have to not do it, not exercise, not walk, etc., until you get therapy. You do it at the same time, But it allows people to stick to the path a lot easier and not fight biology as much. And there's the quote from Dr. Peterson, who wrote the chapter in the Canadian Obesity Guidelines, which is now very widely referenced. Proud to be for this to be from Canada. This is a very common question. How much weight loss is enough? When we talk about, I want to lose 30 pounds, what's the magic number? You want to know? There's no magic number. I'll give you the answer right now. Yes, that's exactly. I'm going to talk about that. That's the definition now. They call it best weight. Many times, your doctor tells you, or maybe you've set that goal for yourself. I'm going to be the same weight that I was in high school. It was 150 pounds. That's my goal weight. It's an unrealistic goal weight. It causes a lot of stress. But in terms of health parameters, you can see how much weight loss is needed to put diabetes into remission, to prevent diabetes and other health conditions. Okay. Typically, they say at least 5% of your body weight is significant weight loss. Not that it's a lot, it means that's where you start to get health benefits at 5%. Okay. And this is what you referred to. The best weight is the way you can achieve and maintain while living the healthiest lifestyle you can enjoy. It's from Obesity Canada. Okay, that's the best weight. They also call it a settling weight. You don't have to continually chase the scale. You have to think beyond the scale. What are the behaviors? I can be at the same weight. That's okay. But what I'm doing, I'm active, my health is good, my LDL is under control, my blood pressure is under control. That's what matters at that point. Okay. Unless you want, for vanity, you want to be a little thinner. That's a different reason. It's an important reason. So it's sustainable, it's health focused, and less shaming and less blame. Any questions so far? You have different chapters. We're going to get through them quickly. The other question people have is, how often should I measure my weight? Should I even measure my weight at all? There's this saying, same with blood pressure, is that what you measure gets controlled. If you like numbers, it helps. If it causes stress, don't bother, really. But you can see that weight fluctuation is a real thing. Weight goes up and down, up and down. You have to look at the trend. And a pound of fat is about 3,500 calories. 3,500 calories. So you can think to yourself, my weight goes up of 5 pounds. And I do this all the time myself, measure my weight in the morning, I'm X number, and I'm a small person. So, I'm 4 or 5 pounds heavier. Did I eat that much food? No, I could not have possibly done that. So you can sleep better knowing that the weight fluctuations are not real weight, both in the upward direction and the south direction. Okay. This is what we're talking about so at 5 years, when people lose weight, most of the weight comes back. It's very difficult long-term. And we don't have a weight loss problem. We have a weight management problem. Again, many of you might be familiar with this, okay, but this is the data to back it up. Dr. Curnew loves studies. There's a study, I like this study. It's called the Look Ahead trial. Among physicians and healthcare providers, this is a very famous study because it was the first study where they tried to put people on intensive lifestyle changes, diet, exercise, everything. And they tried to see if it reduces heart attacks. The trial was negative, but that's a different reason. But you can see at 10 years, only 6%, or the weight reduction was only 6%. We mentioned 5% is significant. It's still good. It's pretty good, but it's not enough to put diabetes into remission, which we need 20, 30 pounds. So diet and lifestyle alone works for some people, not for everybody. And long-term, the weight goes back up. Hence the definition of relapsing, progressive, okay, and chronic. This is the direct trial. This is for diabetes. So they took diabetic patients, they lost weight. After 12 months, a lot of people lost weight. Now this is the 5-year follow-up where only 13% were still in remission. Their diabetes wasn't in remission because of the weight loss. The vast majority of people, the weight had come back up. Initial big success, but the weight has come back up. But the good news is that if you do lose 20 to 30 pounds, and many of you guys have done this in this room, and then you can put diabetes into remission, especially early on. It's especially true in the earliest years of diabetes. If you've lived with diabetes for a longer time and you lose a lot of weight, it becomes more difficult. And that's why we say diabetes into remission and not cured. Your A1C, your average blood sugar, can be controlled. And that's what the aim is. It doesn't exactly solve the problem. And the longer you lived with it, the more difficult it is. So that 20 to 30 pounds, absolutely. It's not as realistic. It's mostly realistic in the first few years, where you can absolutely try, and the pancreas still hasn't given out. You're still making insulin. Later stages, absolutely. But diabetes, that's end stages. It can happen. Absolutely. Yeah. And that's why we're here. And with GLP-1s, the Ozempics and its siblings, I don't know why it's the most successful ones. It's the main character. They help for some people to come off insulin or reduce it. So this tells us why long-term weight loss is difficult. So what they did is they took 50 people, they put them on a very low calorie diet, 500 or so. That's very, very low for 10 weeks. And then they measured their hunger hormones after every meal for 62 weeks, just over a year. And they had this long-term adaptation where after every single meal, they were so hungrier above their baseline. So the body really punishes you for the severe attempt at weight loss. So the takeaway here, two things. One is, yeah, don't go too low with your calories. Keep it as high as possible. But when your still weight is coming down very slowly, typically not more than 1% in a week on average. More than that, you're gonna have problems. We're gonna talk about that a little bit more. The other thing that happens as you try to lose weight, hunger goes up, desire to eat goes up, more so in some people than others. Yeah? And energy expenditure also goes down. You know, the body tries to resist. We know about this. And you lose muscle. And muscle is metabolically active. So as a summary, the direct trial, all these kind of trials, behavior modification, 3 to 5%, bariatric surgery, 20 to 30%. We need a lot more to fill the gap using another tool in the toolbox, which is medication. And that's where the arrow is in there. All right, now we're going to talk about GLP-1s, costs. Any questions so far, comments? I'm going to pause here. Anyone virtual at all? Everyone's quiet there. Anyone know what a GLP-1 is? I'm going to start from the basics. GLP-1 is a hormone. It's a gut hormone. It's made in the gut, in the L cells in the gut, something in the gut, after every meal. So you actually have it naturally. It just doesn't last long. It only lasts 1 or 2 minutes. This fellow right here from Toronto, he still works. And they actually isolated something from this Lia lizard back in, I don't know what the date was. I think it was the 80s or 90s. And they figured that it had this hormone that in rats, it suppressed appetite, it improved blood sugar, and they isolated it in humans and they found this effect. So that's where the medication comes from. Okay, it's natural, so to speak. Of course, what's in the medication is a synthetic version of the same hormone you have so that it lasts longer. I'm going to talk about its effects. Speaking of effects, there's 3 main effects on the brain. So it increases your satiety after meals. That's how it works. It reduces appetite, more so than some people than others. In fact, if you want to tell if the medication has worked or not, that's what you want to measure, not the scale. Is the appetite going down? You know, is my satiety improving after meals? That's the big marker. And the other one is the effect on the stomach. Gastric motility goes down. That's where some of the side effects come by. Constipation, nausea, etc. Gastric emptying slows. If it's too much, for example, someone's having 3 or 4 meals a day, and they go to 1 meal a day, that's too fast. You have to adjust your dose. You don't want to lose muscle. You don't want to get that metabolic adaptation of being at 500, 600 calories and then crushing your metabolism for a very long time. And it helps at the pancreatic level. So pancreas is this organ that releases insulin. But unlike insulin therapy, GLP-1 medication, they only increase your insulin when the blood sugar is too high. So the risk of having too low of a blood sugar is a little bit less by itself. Of course, if you're on other therapies, the risk is different. Other medications, and that's why it's important to double check what you're taking. There's something called a receptor. Receptor is like a key, as in a door. So insulin is a key to get into, that helps sugar get into the cell. Okay, GLP-1 works similar. The receptor itself is everywhere, and that's why it has broad effects. And you might hear in the news, oh, we're testing it out for this, Alzheimer's, this, that, the other, anti-inflammatory effects. Now they're using it for heart failure, people with alcohol reduction, lots of uses. And this is one of the reasons. It's expressed everywhere. It has direct effect, indirect effects in the cardiovascular system. So when we say expressed, is that door is in different places. It's expressed. You know, you have the receptor in your brain, you have it in your gut. Yeah, I don't know why it's not in the liver. Don't quiz me on that. But yeah. But it's everywhere. But the main effects when it comes to obesity treatment is in the brain and the stomach. Right? The rest is beyond my expertise. All right. Now, there's a lot of GLP-1 medications. In fact, if you look at history, there's lots of them. People might have heard of Saxenda, or the older generation one. The ones that's popular now is Ozempic. The molecule itself, the generic name is semaglutide. And there's Mounjaro, which is the new kid on the block. The molecule name for that is tirzepatide. Mounjaro is a diabetic version of it. We're going to talk about this a little bit more, throwing names out there for people who are unfamiliar. Mounjaro is a diabetic version. There's a weight loss version of the same molecule called Zepbound, now available in Canada. It's for insurance purposes. That's why they have different indications. The same molecule. Ozempic and Wegovy are also the same molecule. Ozempic is the diabetic name. Wegovy is the weight loss name. Okay. And some people might have heard of retatrutide. It's another GLP-1 it has 3 components in it. It works a lot better. It has been superior to both of these for weight reduction, upward of 20% of weight loss, getting competitive with bariatric surgery essentially. But it's not out yet. We don't know how much it's going to cost. We don't know about accessibility. We're not going to get into details about this, but some common mistakes when injecting these medications is, this is going to be on YouTube. You can pause and take a look. Some people forget to count 6 seconds, taking out quickly, not sanitizing. We get reactions, not rotating injection sites. Again, we're not going to go over them. Anything to add about this at all? Anything you?
Yeah, I'd say probably the most important thing, questions you get a lot,
I'll just put it here.
Okay. is am I injecting myself or is someone else injecting for me? So the answer to that simple one is you can inject yourself. Every time you get the box, when you open it up the right way, the instructions are there. And it's a once a week injection. You do it at home, as long as you have your needles and your pen with the medication in it, and something to sanitize the area, then you have everything you need to do the injection on your own. It doesn't take like years of training or expertise to do it. They design it.
Yeah, it's just that it's better to know more things to be careful with. You have local reactions that's common, it can happen. Talk to your doctor. Sometimes they can prescribe antihistamines if you have reactions, allergic reactions, local ones, and other things. Okay, and doing it in front of the mirror also helps. Sometimes you sanitize one area and you forget where it was. You put it somewhere else. Yeah.
Preloaded, or do you have to go out yourself?
It's preloaded. There were vials before where you have to, as you said exactly, draw it yourself, but now not anymore. The vials are phased out, so not anymore. There's one more thing I was going to say. You can put it not just in the belly, you can put it in your arms. And some people ask, does it matter where you put it? Doesn't matter. It's personal preference. The efficacy of the drug doesn't matter where you put it.
As long as you are injecting it. You don't want to
That's exactly. It has to be subcutaneous. And one other common mistake is sometimes the needle is not deep enough. So you put it under the skin, but not subcutaneous, not under the complete skin. The liquid still get absorbed, but you might have a little bit of a rough time. So make sure that the needle you don't stab yourself, but it's gently goes in. Okay, and you pinch. I don't think so. The reactions to the components of the medication as opposed to how deep it goes, it's just that sometimes you would have, if it's not deep enough, you see a little bit of a bump forming, which is the liquid is still there and still slowly getting absorbed, which is not what you want. Yeah. All right. This is a lot here. This is more for reference on YouTube. You can look at the efficacy data, how well they work. But what's important is the pill version of it technically works, but it's not available. It only works at high doses. It's called Rybelsus. Same molecule as Ozempic, semaglutide. The reason it doesn't work is that it goes to the stomach. We mentioned it's a hormone. So hormones are proteins. Proteins are digested in the stomach. So they have to give you a lot. 1% of it gets through every day, the pill version. And that's why it doesn't work very well. You have to have it on an empty stomach. And it's not dirt cheap. If it was, we would have used it. It's the same price as the injectables. And that's why we don't use it very much. But in trials, they have used it up to 15 milligrams, 50. That's the Rybelsus. The highest dose available now is 14 milligrams, and the weight reduction is about 3%. That's in diabetics. Non-diabetics, the effect is a little bit higher. Okay? And you can see the levels here. So when deciding which one to go with, Mounjaro is actually the superior one at this stage because it has this dual agonist. We're going to talk about what that means. The average weight loss with diabetes at its max dose is about 11 to 12% there. But with non-diabetics, the Zepbound one, 21%. So the reason diabetics lose less weight is because of that. So this is more if you're curious why. There's an enzyme that breaks down this hormone. It's called DPP4. And it's chronically overexpressed in patients who have diabetes. And this is one of the reasons why you see less weight reduction with type 2 diabetes. You have to go to a higher dose that you can, essentially. That's the reason. And there's other reasons too. You're on insulin. That kind of makes things complicated for weight loss. Anything to say about this at all? I think the most important thing is the Wegovy you can see at its max dose, 15% body weight. That's 104 weeks. Do the math. How many years is that? It's about 2 years. With tirzepatide, Mounjaro, again, we said 20%. And this, what we have highlighted here is that they've also given it to people for stroke and heart attack reduction. And they saw that people who had previous heart attack, they reduced the risk further by an extra 20%, right? And with heart failure, people would have it. So it's not just used for weight loss now, it's for cardiovascular prevention, right? It has this broad effect. That's what we talked about, the anti-inflammatory. A little bit controversial in the cardiology world. People say there's a reduction just from the weight loss. Most of it is, but it also has a little bit of anti-inflammatory effect. And also for renal decline, they're seeing 24% for preventing dialysis, people who have chronic kidney disease, renal dysfunction. So if to manage expectations, you know that if you're diabetic, how much weight you're going to lose. That when you compare yourself to the next door neighbor, you know what the data is coming from. So this diagram here shows the difference between semaglutide and tirzepatide. Semaglutide is a GLP-1 agonist, so it just mimics one hormone, whereas tirzepatide is a GLP-1 and a GIP agonist. GIP is another hormone, okay? And its effect is mainly in the brain, as opposed to the gut. And some people say tirzepatide helps them a little bit more with this something called food noise, craving, snacking. As GLP-1 from semaglutide has a stronger effect on the gut. It slows gastric emptying a little bit more. And it's part of the reason the side effect profile is a little bit better on Mounjaro's side than semaglutide. They're very similar, but a little bit better on tirzepatide, because most of the side effect comes from the GLP-1 effect, the stomach emptying, being slowed down. But even though the GLP-1 effect of tirzepatide is a little bit weaker, because of that extra hormone called GIP, the whole total weight loss is around 20% in non-diabetics, and that's what works better. And then the newer agents, retatrutide that I mentioned, that's 3 agonists. We're not going to talk about that. But it gives more people hope, because some people still plateau and don't lose a lot of weight on these dual agonists, on the tirzepatide, on the maximum dose. So as we said, we need all the tools in the toolbox. Okay. This is the safety data. When we say safety, we're really referring to the nausea, the vomiting, the constipation, the diarrhea, what stops people from taking it because of side effects. And you can pause and take a look at some of the comparisons. So this one, SURMOUNT-5, name of the trial, as you mentioned, this is with tirzepatide. Tirzepatide right there, tirzepatide versus semaglutide. On 15 milligrams, 76% had side effects. Okay, that's a lot. So they're very common. Most of it is self-resolving after you start therapy. Okay. On Wegovy, which is 2.4, semaglutide, which is the molecule, 79%, roughly similar. But this is the headline here, is that in this head-to-head trial, comparing this medication with that, 8% stopped semaglutide versus 6.1 for tirzepatide. And because of GI side effects specifically, it was 5.6% versus 2.7% with Mounjaro. The Mounjaro a little bit better side effect profile. Okay. But individual effects, of course, varies. Any questions about this at all? We're going to talk about how to manage and its side effect. This is cost. Cost is probably the biggest barrier here. Mounjaro is the most expensive, about $800 to $900 the max dose. Ozempic is around $270. Wegovy is around $480. If you have private coverage, we're going to talk about coverage in a moment. That's the way to go. But out of pocket, these are out of pocket expenses. Shopper is the most expensive one. I'm not sure why. So their markup is more expensive. So sometimes with these medications, I'm going to call around, ask, especially with Mounjaro, not so much with Ozempic and Wegovy, a little bit more stable. We should talk about coverage a lot, because this is very important to clarify who can get coverage and who not. I'll pass it off to you with this.
Yeah. And so really with the prices that we talked about being, quite high, this is actually one of the things that will be a big predictor of which one you actually end up on if you're interested. One being, do you have diabetes, or are you just doing this for weight loss? And 2 being, are you paying out of pocket, or will you have insurance coverage? So the more straightforward ones to talk about, I'd say, are the diabetes medications. So like we said, the 2 medications are semaglutide, tirzepatide, but they all have like 2 brand names of each. So the ones for diabetes are Ozempic and Mounjaro. And so when you look at which one will you get covered by the government, that would be Ozempic if you have diabetes. Specifically, if you have diabetes, and there's other caveats as well, like have you tried metformin, was it unsuccessful? Mounjaro, even though you may have diabetes, you're not going to necessarily get public coverage from the government. but you can get private insurance coverage if you have diabetes. You'll have to fill out the forms, which will help you out with. But there are some caveats. So usually it's good to just check with your insurance first because it can differ depending on the company, depending on your specific plan. And then, so those are the diabetes medications. When it comes to the weight loss ones, yeah, so Zepbound, Wegovy are the ones targeted, or I should say branded, for weight loss. So these ones, you're not going to be getting government coverage, but some insurance companies will cover them or help you pay for it. Yeah. So with Wegovy, that's the one that we're seeing the most right now since Zepbound is so new. I'd say most insurance companies nowadays are covering it.
More and more, that 20% is coming from a few years ago.
Yeah.
More and more are starting to cover it.
Yeah.
Because of
Well, I
Obesity
looked it
Canada.
up and it has to be, you have to have the BMI over
Yes.
30.
Yeah.
And also you have to prove that you tried other things.
Absolutely. And
similar.
that's the frustration because,
Yeah.
hence, I think we talked about why, because it's a disease process. We don't say with other diseases, chronic diseases, first try this. When we know we're going to, most people fail. Right? And maybe fail is not the right word. Most people are going to struggle with just eating
Yeah,
less.
Exactly. Yeah.
Yeah.
And that's why, so how we can help with the insurance is in the prior authorization forms. We try to really sell your case to your insurance company, explaining that not only is it just a BMI, but what comorbidities might you have? What have you tried in the past? And why do you need specifically to be on Wegovy? Why is it so important that you get support in having these medications?
Which is nonsense, by the way. We talked about why. As you mentioned, so the criteria for Wegovy, the BMI of 30, we talked about why that's problematic, BMI and its problems, or 27 BMI plus weight-related complications. What that means in plain English is hypertension, sleep apnea, dyslipidemia. Dyslipidemia means your LDL is too high, triglycerides are too high. That's what that means. Your cholesterol is too high. Or you have diabetes or pre-diabetes. Those are weight-related complications. The other ones like osteoarthritis, we had a video recently about that, and other things. Mechanical stress, okay? So cost, let me go back to this cost slide here. This is very important. So the manufacturer of Mounjaro and Zepbound, so Eli Lilly, that's the company, they put this discount, not sure how long it's going to last. I asked the pharmacist, they said probably going to last a little bit more because Ozempic is going to go generic in 2026. We haven't heard about details, when, how cheap it's going to be, but to remain competitive in the Canadian market, they're probably going to still offer that discount. It's a good discount, 40% on the bigger pen. And when you consider the discount, and there's something called counting clicks, we're going to talk about that. The monthly cost of Mounjaro can actually be as low as $83 on 10 clicks. 5 milligrams, $170. A lot cheaper than Ozempic and Wegovy. And the lower starting doses of Mounjaro, somewhere around 10 to 20 clicks, are the same efficacy at the higher doses of Wegovy and Ozempic, roughly, by extrapolation. Okay.
You also mentioned Zepbound is rough. It's pretty competitive in terms of pricing, pretty similar to Mounjaro.
Yeah. And that's the website people have to go to get the discount card. You take it to your pharmacy. mymounjaro.ca or myzepbound.ca. The myzepbound.ca discount it's an amount off as opposed to a percentage. We did the math, and the Mounjaro was a little bit cheaper, more competitive than the myzepbound one. We want to talk about more of these after. And there's also something called InnoviCares. Anyone has heard of InnoviCares at all? Yeah, so InnoviCares covers a little bit of it gives you a little bit of a discount on brand medications. So Wegovy is a brand name. There's no generic, of course. You can get, I think you can get it for Ozempic and Wegovy, if I'm not mistaken, this card. You don't need the card itself. I'm not quite sure what the percentage, I think it's around 5% or 10% or so. It's not a lot, absolutely. So, but it's like, yeah, it's not a lot. It's not a lot. And even some of the discount cards that we have, we've asked some of the patients, and it's not super significant, but it's still something. Still something. The major thing is the Mounjaro, mymounjaro.ca discount. Okay, so who is this medication not for? One is an arguable, but intolerable side effects that's not resolving after at least 8 weeks. Okay, so we're talking about nausea, vomiting, of course, personal preference. Typically what happens is that the starting doses of these medications is for many people is too high. So it's actually, we're going to talk about a study where they took people, started them at very low clicks, very low doses, below what they tested in the trials, and a lot of less people stopped over time because of the side effects. So the slower you rise, the safer it is, as opposed to starting with very regimented to what it says on the prescription, this, that, the other. Yeah, absolutely. Absolutely. And if there's one tip to give about these is exactly start slow. And that and dietary modifications, of course. There's also something, so you might hear news, you know, somebody went blind, this, that, the other. Most of that is very rare cases. And when we're thinking about any medical invention has risk, the reason we use this is because the benefits are here and the risks are, you know, the relative risk and benefit is, it makes sense. Otherwise, we wouldn't do it. So we can pause and take a look at this. Drug-drug interactions, ask your pharmacist about this. But some of the main ones is thyroid medications. Sometimes the dose has to be adjusted. Things like antipsychotics, SSRIs, not a big difference. Maybe some certain brands can be a little bit different, but that's the main one is with levothyroxine, a thyroid pill. Oral contraceptives can have a little bit of effect there. You're gonna have to discuss that. For most medications, it doesn't have a direct effect. Warfarin, digoxin has a little bit of effect there, but not significant. Of course, before surgery, because the food stays in your stomach for longer, you typically ask to stop at a certain duration before. That's the other thing that you have to do. People with poor kidney function, I think up to 15 EGFR, which is your filtration rate, it can be used. In fact, we mentioned that this medication is used for people with renal disease, right? But below that, different case and caution. And a little bit of a caution with people who are on insulin and some medication called sulfonylureas. So example of that is sitagliptin, for example, and glitip and others. So side effects so these are the rare side effects. So we have gallbladder complications. That typically happens with rapid weight loss. That's why weight loss has to be slow and steady, not more than 1% or 2%, being liberal here, not more than 1%. You know, if you have a bigger body, of course, maybe 1% can be a little bit safer above that, but most people 1% or less. Acute pancreatitis, so inflammation of the pancreas, that's what that means. People with a history of pancreatitis technically shouldn't be on this medication. Some physicians, if the benefits outweigh the risks, might still do that. But that's one thing. The symptom of it to look out for is, you know, radiating and pain that you can't tolerate in your abdomen. That's radiating. That's one example. Diabetic retinopathy. That happens with extreme rapid improvement over A1C, typically more than 2% in 3 to 6 months. Most people don't have that effect, but it can happen. Right? So making sure that if your blood sugar has been high for a long time, it doesn't improve too rapidly. Otherwise, you can have some of these eye complications there. So counting clicks and microdosing. So microdosing is a term some people like, some people don't like, but it allows to manage costs, of course, as we mentioned. It allows for side effect management, so you go slow. It can cause confusion in some people if you get it slightly wrong. For example, 30 clicks versus 31 clicks, that extra click can give you partial doses at the end. We're going to give you a chart that says which clicks are best. What I mean by partial doses is that it's not even. The pen has a total of 72 clicks. It has to be divisible by 72, for example, so that at week 6, when the pen is expected to be done, when you dial, that's it. That's it. You don't have any partial clicks where, oh, I have 7 clicks left. I'm going to give myself the 7 clicks and do the math with a new pen, give myself 13 clicks to 920. So you don't want to do that. You want to keep things simple. Something people forget is that you don't have to count every week, right? You can count once if you're in a consistent dose and you're maintaining. Grab a pen or marker, put a marker, and just go there. Right? So common sense, but many people forget that. This is the study we were talking about. Flexible titration versus going with a label, going slow. So you can see here, this is the typical titration of Ozempic, 0.25 in the first 4 weeks, then 0.5, then 1 milligram very quickly. 19% withdrew because of side effects in this group. Whereas the other group, they started at 5 clicks and added 5 clicks every subsequent week, and only 2% dropped out because of side effects. So this study, the citations here for any experts looking at online. It's a good study to look at. Managing side effects, there's different side effects, right? Different dietary modifications are required for each one, but these are the big ones. Avoiding having small and more frequent meals, cutting the plate in half. You don't have to eat like that, by the way. That's just a joke. Okay. Took it from social media. At the top, it said, Happy Thanksgiving, Zempic. You don't have to eat like that. It has a little bit of fiber and protein in there, though, so that's good. Avoiding large meals, especially in the first few weeks. You can be more flexible as time goes on, but the first few weeks, you have to be very careful. Low fat meals, low sugar, low spice, avoiding ultra processed foods. That's what UPF stands for. Avoiding a high alcohol use. Typically, alcohol can exacerbate some symptoms. Pancreatitis it can happen because of alcohol use. If you have high triglycerides, be careful there. If you have a little bit of nausea, you want to use soft plant foods. So oatmeal, yogurt, some type of yogurts, apples, soups, crackers until it subsides. Again, most of it is self-resolving. The nausea center in the brain gets used to it, but the medication still works at the end and the nausea is managed. So most of the nausea is in the first few weeks. The long-term ones is constipation, diarrhea, both ends of the spectrum. It's because of the gastric mobility that's slowed down. You have to manage that with fiber, water, movement, that triple combination. But some people have other challenges where have irritable bowel syndrome. They have to ask their doctors the other causes for continual constipation or diarrhea. Yeah, yes, that's interesting. So if you go a long time without eating, it can exacerbate with some people the nausea. So that's why you want to have small meals. Absolutely, it's mainly for the nausea. Yeah, or if someone has diabetes, for example, going a long time without food, so-called intermittent fasting, can be a little tricky. So it's typically, it has to be managed. Yeah.
Main meal is my dinner. Now, I'm very active, I have grandchildren and I take care of my daughter and stuff like that. But I'm always on the go and I don't eat.
Yeah.
So, just years, but I don't. I try. I take a piece of, I don't have time in the morning to do so. But even if I used to grab a banana. Well, banana is not good for a diabetic because it has 7 teaspoons of sugar in it.
Yeah.
Right, so I avoided that. But sometimes I'll have lunch, sometimes I won't. But mainly I have a meal at dinner and that's it.
Yeah. This is especially important for people who are on insulin therapy, for example. The more controlled diabetes, they call it, it's less of a risk to go a long time without eating. But if you're on insulin, the risk is a little higher of having a hypoglycemic event, low blood sugar. Yeah. But for GLP-1, just because of nausea. And then long term, there's a little tip, having a glass of water before every meal. So for some people, dehydration can happen. You forget to drink. Your thirst can go down because you're not as hungry. You just forget to eat. That shouldn't happen. If that happens and you're not eating a lot, you have to manage the dose there. Protein and fiber with every meal. People talk about how much protein I should have. There's a protein craze right now. 100 grams of protein, 100 grams that. Unless you're a bodybuilder, go ahead and count. For most of us, just make sure you have protein and fiber at every meal. If that's your focus, you're doing well. Good sources of protein: beans, lentils, lean meats, right? And fiber from a variety of sources. So the more color you have in your diet, it's the best. Right? You have peppers, spinach. Yeah, go ahead.
So where do you get most of your protein? To me, it's not important that you get it all. People talk about after exercise, whatever. That's
total. What matters is total.
Yeah. And so, what are people's number one source of protein? Where do you get most of your good proteins from? What do people do?
Meat.
Okay. Meat actually okay. So one of the things is that meat is certainly a very tasty food, but it's not a really healthy food. On three reasons. One, you kill animals. Number two, it's bad for the environment, and it's also bad for you. Now, the worst is processed meat. So, one of the worst. Yeah, that slide there. Go that slide there. This is a great slide. Take a picture of that, guys, if you want to, or go back to.
On YouTube as well.
Yeah, no, but it's really. I find, to me, one of the things is that I'm eating a lot of egg whites. My wife loves Greek yogurt. I get the low-fat version of it. And I think the best source of protein in the world is beans.
And Greek yogurt.
I'm sorry?
And 0% Greek yogurt.
Yeah, but if you look from a perspective, is that, beans to me is an Ozempic-like drug. Makes me feel, I try to have like a half a cup to a cup of beans per day. And, meat has gone up in price. And I think we should actually ban it from the planet. From my, like I was just saying, is it's just expensive and it's not good for you. It does have good iron absorption rate from its, and it does have some good protein, but it has a lot of bad stuff in there too as well. Carcinogenic. And the worst thing is, what's the worst meat?
Salami.
Yeah, so I always say bacon is cancer on a stick. And so I mean I love that stuff, but I try not to. Now one of my downfalls, I hate this, is that my Tim Hortons app gives me like
Offers.
these offers, and you get a coffee and one of those egg McMuffin things, and the best pricing of it is the one that has bacon in it. Now if I'm really good, I take the bacon, I'll give it to the dogs.
Yeah.
But if you get the cheese one, do they get more cheese? Or
That's something you should know.
is that and but that's my treat, and so I really have to think about this. If you can try to add in beans to every meal and try to get to 30 grams of fiber a day, that would be fantastic.
What happens when we stop using the medications? We mentioned that obesity is a chronic relapsing disease, so it's not a surprise that the vast majority of people, and they've tested this empirically, the weight comes back up. You can see the stats there. So this is for Wegovy, semaglutide. People were on therapy for 68 weeks, just for over a year, and then they just said goodbye. Placebo group and the actual treatment group, I'm gonna just on your own without therapy, see what happens. The placebo group started gaining weight on placebo, and the actual treatment group also started gaining weight. So 2/3 of people started gaining weight, and they gained 11% weight body weight back, which is quite a bit. They had lost 16%, they gained 11%, still below baseline, up 5 to 6%, not bad. And you see something similar with tirzepatide. In this study, they kept one group going, the treatment group still on therapy. The line is still low. They kept the weight off. But half of the other people, they were on placebo instead of the real pill, and the medication comes, and the weight comes back up. You see. So this is what happens. But on Reddit, I'm talking about Reddit, I'm not sure if people know on social media, different people have different experiences. So on Reddit, there's a subgroup called GLP-1 grad. So some people stop therapy because of cost, because of side effects, and they can keep the weight off. Their biology is different. Like if you've had a struggle with weight, the same pounds coming off, coming on, you have to try your best to be on some sort of therapy. And the dose that you start on doesn't have to be the dose that you stay on long term. Sometimes you can see that you can keep the weight off at a lower dose for cost. You don't have to always be at 1 milligrams. You can be at 0.5, your appetite is still controlled, and you made some changes. You still have the fuel in the fire, which is the GLP-1 in the background, and you're getting good effects, right? So there's this $1 million question: how long should I stay on GLP-1? Ideally, lifelong. Why? Not because this pharmaceutical company, although that's a problem, conflicts of interest that they have, absolutely, but also because it's a chronic disease when it comes back up. So it depends on the person. If you grasp at the straws and try your absolute best, make some of the changes. In fact, even with bariatric surgery, we see that weight loss is not that dramatic. People can still gain weight back because of cravings, right? So it doesn't solve the entire issue; it just solves the gut issue, but not the brain challenge. This is the predictor. So there's something called the National Weight Control Register in the US. If you track people who have successfully kept the weight off, people like yourself, and many others. Yeah, it's really good. So what they're doing is they don't count calories, but they're calorie aware. So I know that, this muffin from Tim Hortons, how much it is. It's a quarter of my actual total daily calories for you. I know that. And you just get roughly aware of how much things cost. Just like how you know how the cost of the banana or cost of meat, you should know the calories, what you're putting in your body. Same exact thing. They self-weigh on a regular basis. So post-monitoring, but flexible. So you can have desserts. You have to have fun. So the best diet is the one you can stick to long term. Right? It's not the keto diet, plant-based diet. Just the one. In fact, most people, what you've eaten the last 50 years is probably what you're gonna.
So you know how earlier I said that I started off slow and gradually went? Well,
With the clicks,
you go the same way when you want to get off too.
you don't
You
have
know
to.
what I mean? Instead of going cold
yeah,
turkey and
yeah,
saying
yeah.
the hell with it, and maybe that's why I've so far kept it up. You know what I'm
Yeah,
saying?
yeah, yeah.
Like, you have to, because that way you're training yourself at the same time. So I don't eat as much because I've been training for that for, you know what I mean?
Yeah, you make some habits.
Yeah,
Habits
and
change your dietary patterns, and you can just keep going. Absolutely.
Yeah.
And that's why it says for some people they can do it to some extent. But for some people the weight still comes back up. Okay. The other one is some sort of physical activity. And it's odd that we're going to talk about why weight loss is exercise is not great for weight loss, but it's somehow great for weight management. It has directly, indirectly. The analogy I like to use is like being an athlete. Because you're exercising indirectly, you want to show up fit for preseason, so you also keep track of your meals. You avoid that extra brownie. You don't go to the fridge as much because you're exercising. You don't want to undo it. Of course, there's different effects with exercise. Some people appetite go up after exercise. Some people, and we know that physical activity attenuates appetite. Broad effects. But this is what we see from observational studies. The people who keep the weight off are doing these things. And you can stop and take a look. We talked about this quote: what gets measured, gets managed, and gets controlled. So self-weighing is important. We talk about body composition. This is a picture of how much muscle. So this is in kilograms. 4 pounds of fat, 4 pounds of muscle, right? Muscle is more metabolically active. It burns more calories at rest. When you lose weight, 25%, so natural weight loss, 25% of it is usually lean mass of muscle. Nothing to be scared of. It happens naturally when you weigh less. Minimize it, you have to lift heavy. That's the main thing. And a high protein diet. And this shows it right here. So typical is 25% lean mass loss. The high protein diet, you can get that as low as 10%, 11%. Still not zero. Okay, but what matters is strength, is actual function. That's what matters. Unless you really care about muscle. Again, diet, exercise, combination, that's how you can muscle off on these medications. Natural weight loss, the same thing. This is a very interesting study. Who's heard of the NIH in the US? Very famous place, NIH. Our medical student over there might have heard of the NIH. So they did this study of 20 people randomized an inpatient ward for I think it was 2 weeks or so. They gave them an ultra processed diet at random and a minimally processed diet. In fact, it was very interesting. They controlled everything. People were in gowns. They couldn't tell if they were losing weight by their pant size and everything. And after 2 weeks, spontaneously, people on the ultra processed diet, they eat an extra 500 calories more and put on weight. So this just tells you when the food is more hyper palatable, without counting calories, whatever, without being aware, you just eat more of it. So one of the biggest fixes or low hanging fruit is to go from ultra processed to minimum processed, whole food base. That already cuts on calories. Of course, that's not enough for significant weight loss, but it's one of those keys in the toolbox, right? It's one of those key things to do. So I'm not going to play the video here, but for people online, this person, he's in Montreal. He's a food coach, but he has these food comparisons online that says you can have the exact same diet, but small differences in the oil you use, the kind of meat you use, can make all the difference for calories. So in other words, you can eat healthy, but you're still eating, it's quite small, but total calories, 3,200 calories in a day, with the exact same ingredients almost. A little bit less amount of this, a little bit less of that, cooked with an air fryer instead of oil. And it makes all the difference. And this side, which is 1,800 calories, also has an extra dessert. So it has an extra ice cream. So you have to learn a little bit about calories. Not counting them, it can cause stress. It's very difficult to do, but being flexible with them. So you can check out his videos, and he gives you a lot of ideas of what to actually eat. Right. So it gives you this ingredient, that ingredient, what is healthy, what is not. Intermittent fasting, we spoke about this a little bit, has pros and cons, better for shift workers. If you're busy, right now we're not eating, you can fast, not think about food. Unfortunately, there has some downsides to it. People lose a little bit more lean mass with intermittent fasting because naturally you don't eat as much. You lose weight a little bit quicker. Your protein is not as high when you have 1 or 2 meals a day in 6 or 8 hours. But if you make it flexible, 10 hours instead of whatever, well, you have some kind of meals or snacks, protein snacks, and the rest of the day, you don't actually fast with the true definition of the word. It's a little bit better. So it's tough to follow for a very long time. If you're on GLP-1s, if you're diabetic, it can make nausea a little bit worse than some people. You mentioned that. Risk of hypoglycemia, etc. But you have to weigh the pros and the cons. It's a tool in the toolbox. If it works for you, it actually works quite well to keep the calories and maintenance. But it's not superior to just calorie restriction. It's just a tool to keep the calories low. That's all. Because some people think, oh, fasting is this magic drug. A lot of people sell the idea of fasting. There's nothing special about it. It just makes you lose weight. Movement. Talk about movement. I'll
Alright.
pass it off to you.
Onto the kinesiology side of things. So, talking about exercise, so we talked already about the fact that exercise on its own is not going to do too much in terms of weight loss exclusively. We got this study here that shows that adding exercise to your diet or to your calorie restriction isn't actually all that different from just restricting the calories. So adding on exercise into your routines is not necessarily going to lose you more weight initially, but we did talk about how it can help with the maintenance. So walking enough.
Yeah.
So is walking enough? So this is the big challenge that we kind of have, is that everyone's going to be at different levels of ability and what kind of exercise you can do. So a lot of people love walking, which is great to be walking. You know, just famously, a lot of people like to aim for the 10,000 steps. It's more so around 7,000 that we see the benefits start to kind of plateau and taper off. But walking alone is not something that's going to be the big game changer, be the difference maker. And we'll talk a little bit more about what we can do instead, because resistance training, weightlifting sounds daunting at first. Sounds like it's something only for the big athletes that get paid millions of dollars, or the bodybuilders who are, you know, in the prime of their lives, I guess, supposedly. But we actually have to appreciate that resistance training is truly for everyone and will look different for everyone.
You want to talk about this or resistance first?
We'll talk about
Yeah, we'll talk about this first.
Yeah.
Yeah, go ahead.
So generally, as we were talking about, exercise not necessarily gonna get you W's on the scale, big wins on the scale. There's actually a lot of other benefits that you're going to be getting from doing exercise.
Even without weight loss.
Even without the weight loss. That's the big important asterisk there. And one of those from this big meta-analysis, looking at a ton of different trials, was looking at how exercise actually affects the visceral fat. So we were talking about visceral fat being the bad fat wrapped all around your organs that can create some problems in the future. So even though we don't claim exercise as spot reducing fat, specifically taking out, you know, getting you the 6-pack abs, we still actually see some pretty interesting results in visceral fat reductions when you're exercising. Some higher intensity exercise seems to be better, but what does high intensity mean? That's something we're going to talk about. It doesn't necessarily mean sprinting all out or lifting 500 pounds. It's going to be, again, different for everyone. So don't get afraid when you hear high intensity.
Yeah. Yeah, I call it as it's a zone where it's comfortably hard. You know, it's comfortably hard. Yeah.
I could actually I think you have to also, that's okay for a little bit of zone 2 training, but
No, absolutely.
I think full intensity is actually important. You know, the quickest way actually is 4 minutes, the hardest thing you can do, and you're dead, and 4-minute rest, and do that 6 times. Now, not saying you should all do that, but I think one of the things is that it has to be hard. It really push yourself to lose weight, I think, and whatever hard is for yourself. To me, one thing I find very hard is swimming. It's
That's true.
and for many of us, just a high intensity swim is actually good for the joint, but it's really hard on yourself. But it doesn't go against gravity, so you're not gonna lose any weight of that, but it's gonna train you to do other things as well. And to build bone, jumping and things of that nature, but it takes a while you don't want to injure yourself. So I'm gonna say there has to be a component in my mind of a very high intensity. You don't see too many marathon runners that are overweight.
Actually, in the summer, that's how I exercise. I do 15 laps in the pool because you're using every muscle in your body.
So I try switching to like a rowing machine, get to a little bit more and just try to add some more.
Yeah, but I enjoy the pool more than I would enjoy the.
You want to enjoy
Whatever you can do for longest, yeah, absolutely.
Again, it's gotta be,
One of the things I'm
Hence
finding
the
great
title there.
difficulty is building muscle, and it gets hard as you get older in life. But you need to actually exhaust muscles. You need to push it to a point where you try between 4 to say 10 reps, and you can only do maybe 1 or 2 more, and that's it. And you're really dead. And but you don't want to injure yourself, and you need to have the right people around you to help you. So I'm privileged to work with people that can
help that work.
I didn't start off with 50, just so you know.
Yeah. I'm just saying is that we have to come out of our comfort zone right now, because in the sense of, I hurt myself in the past, but also more importantly, I didn't push myself enough either as well. And so you have to then create the proper form and technique and people around. I'm going to tell you about other programs. One is PACE and other programs too as well. These are fantastic places to go if you want to.
I did a water aerobics
Yeah.
thing at a community pool, and you actually sweat while you're doing the aerobics, and you're in the water, which is cool. And then afterwards, I used to do laps afterwards, and you're exhausted when you're done.
I actually put my feet over my pool in the tank, and then I go under the water, then I come back up.
Nice.
The water is my weight, basically.
Yeah, yeah. Go ahead.
I'll let you
Resistance
go.
training, muscle now. Go ahead.
So right.
Right, yeah, so resistance training.
You can.
Okay,
This
so
is important. Yeah, go
this
ahead.
is very important. We're gonna talk about a big kind of 1-2 punch of muscle loss. So one, we're all doing this, we're all getting older, we're all aging, and so that already on its own is a big driver of muscle loss. So the big statistic we like to say to clarify things, you lose 50% of your muscle mass after the age of 30. So like Dr. Curnew was saying, you kind of hit your peak around 25, 30, and after that you start declining, but it's not all doom and gloom. There's things you can do to preserve that muscle.
So bed rest, you can see you lose 2% or in a hospital. Hence why being hospitalized is one of the worst things. I don't want to be too pessimistic. Things happen in life, of course, but it does harm.
No, there's that physiotherapist I showed that there's what's that guy's name?
Willie Hollow.
Will Harlow?
Yeah.
This guy is a really good guy to work on the internet. We'll send you a link to that. I was looking at something last night. He took a bunch of 80-year-olds and built muscle with them. It was only about 10-15 minutes a few times a week. I can't believe so, but with bands mostly. And so there's ways but there's also been shown that a lot of people in their 70s and 80s take twice as long to build muscle compared to 50s. And these guys are still you look at them, they build muscle. You look at me, I'm losing
Not
muscle.
me.
But it just takes a lot more work, and you have to have fun doing it. So you run around the squash up, you're almost dead, and you do 20 push-up, burpees, and whatever, then you throw up and play again, And but you a bunch of other people, you have fun. They like lose twice as much. February's push-up challenge. How many push-ups in February?
2000.
2,000.
It's in 23 days. I don't know why 23 days, but
So you don't do them all at once, but the guy he did them all the first week.
Oh, God. Oh,
it doesn't have to be push-ups, but you can do lunges, you can do chair squats, you can do knee push-ups, wall push-ups. That's quite good.
This is the extent of mine, right here.
Go ahead.
I can't really do that with the other leg, but really messed up.
Yeah, like you need sleeping.
Yeah, no.
Yeah. So, like I was saying, when you're aging, muscle is going to go down, but resistance training can preserve it. So this study looked at what they did when they did a year of heavy resistance training in seniors. And you can see after 1 year, that purple line, how much their strength increased. And even 4 years later, even with that muscle loss that they were seeing when they weren't doing training anymore, even with that drop, it's still the same. That level of strength is still the same as how they were at baseline.
And above, so they had this control group and no training group, and they're way above that. So in other words, aerobics, you have to do it all the time to maintain your fitness. You gain it quickly, you lose it quickly. Muscle stays on a little bit more. So you invest a year of heavy resistance training, you weeks with a personal trainer, and you reap you keep the strength, for 4 years later. And actually the last thing you lose is the muscle mass. First you lose speed, then strength, and about the different muscle fibers. That doesn't matter as much.
Nuance, yeah.
Idea is, I think what I say is don't make it complicated. I heard from a physiotherapist that said, people say, do I need a personal trainer? Any movement where you're pushing, pulling, and you're doing squats, that's it. Just focus on that. And you can find variations at home to do. The only thing is this, if you can do it forever, and not get tired, then it's an aerobic exercise. It has to be tough. To get health benefits from walking, rowing, it doesn't have to be that tough, comfortably hard, easy. You can chat. With resistance training, it has to be a little tough. You have to push yourself every week. They say this is a good slide, rule of thumb, go to 1 to 2 reps of failure a week. You can't do it anymore. So you're doing wall push-ups, We make it difficult every week by standing a little bit farther back as long as it's, safe. We're doing squats, the big muscles that you have to get up and get down from the chair. Grab a kettlebell in front of you, a water jug, something heavy in front of you. And you don't have to go all the way down. And there's also something called isometric where you hold the position like wall sits. It reduces your blood pressure and it keeps strength. It's not going to keep muscle mass, but it keeps strength. And you see plenty of centenarians, people who live to 100 people. They're not big people, right? They look frail, they're skinny people. In other words, you don't have to have a lot of muscle. Strength is what matters. Follow that, right? I think that's. And you have some examples here.
Yeah.
That's push-ups, yeah. Going
Yeah,
back?
this one.
This
Yeah,
one? Yeah.
this one right here. Yeah, so I was talking about how there's a little 1-2 punch going on. So the first one is aging, which naturally will lead to muscle loss. The other one is weight loss. So if you are successfully losing weight, it's not, unfortunately, not purely fat. That also includes muscle. So one of the big concerns or one of the big fears when people are taking GLP-1s, people worry about what's going to happen to my muscles, what's going to happen to my bones. Well, if you're losing weight and you're successful with it, part of that will have to be muscle, unfortunately.
And
So
lower.
what we need to do with resistance training is try to preserve as much muscle as we can so that even if we are losing a little bit of muscle, the cost of losing that little bit of muscle is not, or it is outweighed by the benefit of losing the weight.
From
overall.
here.
Yeah. So looking at this study, for example, the group in black, you can see how far down that bar goes. That's how much their lean mass went down with just dieting and losing weight. But with the white, which is half as much of a drop, that's what exercise did. So they didn't lose as much. They lost about half of that mainly from their legs, a little bit of benefit in the upper extremities or UE. But the important thing is you're seeing that muscle loss cut in half pretty much by doing some training.
What you don't want to do, I was just thinking about it, you don't want to do ab crunches. That's something you don't want to do. You want to do functional exercises. That's why the push, pull, getting up, getting down. Yeah. The things you use in real life. And there's some ideas here. So you can you can use bands at home. Gyms are an intimidating place even for me. I avoid it. You don't. You're the exerciser in the gym. But you can do things at home with bands, weights, body weight alone, etc. Pyramid of weight loss. So the most important thing is calorie deficits. However you achieve that, intermittent fasting, GLP-1, etc. Then it's weightlifting. Then it's protein intake. Then it's sleep. Anyone know why sleep is important at all?
I know, because it helps your body heal whatever needs to be healed.
Yeah, that's one of them. But for weight loss specifically, it keeps your appetite in check. You've seen those videos where you're an hour, 2 hours sleep deprived. You crave more food, snack more, happens all the time. Spontaneously eat more. That's the big reason why sleep is important. And for some people to say, what are your low-hanging fruits? Forget about calories. If you're not sleeping enough, reaching for food, late night eater, always reaching for food, what's your sleep looking like? That's a good question. And cardio is at the top. It's not that it's bad, it's just that for weight loss specifically, you shouldn't be chasing calories burned. You should just be chasing. Think beyond the scale. We had that slide about beyond the scale. Think about what's my fitness. And when I say beyond the scale, look at the metabolic parameter. What's my LDL? What's my blood pressure? What's my waist circumference? Those are the metrics, even though if the weight's not changing. Because some people chase the scale and people say, my goal weight is 160 pounds. I'm at 190. I've been at 190 for a long time. I've lost 100 pounds, but I want to get 20%, 20 more pounds. Why? Then chase the health parameter. That's the most important thing. And focus on doing some kind of resistance training, some kind of exercise. So that's what matters. These are things you can do at home. So these are the resources. I'll let you talk about patience.
Go back to the take-home points really quick.
This one? Yeah,
Yeah.
go ahead.
So just in a quick nutshell, what's the takeaway about exercise? What should you know when you go home and think, okay, well, how do I actually do exercise? What am I aiming for? Well, as you said, aerobic training, cardio is not the biggest thing for weight loss, but it's still important for those off the scale benefits. So in terms of what you can aim for, 30 to 60 minutes per day is the guideline most days per week from Obesity Canada. Although, that's going to be hard to get to right away. You're not going to wake up tomorrow and you're suddenly an athlete. You have to kind of build it up slowly. Start with what you can do. Start with what fits into your schedule, fits into your routines, and try and build it up slowly. And then intensity is the big one we want to talk about, because what we kind of see with some of these people that mention exercise didn't do anything for them. Some people it works really well, some people it doesn't. you might not be getting the right dose of exercise. Just like with any medicine, if you're not taking it enough, if you're not at a high enough dose, same thing. The biggest thing to think about in terms of what's your exercise prescription or dose is the intensity. Are you actually challenging yourself enough? So when you think of aerobic training, how do you gauge that? Well, there's something called what we call the talk test. If you're doing your exercise and you can hold a conversation, if you can talk as easily as I'm talking now, that's pretty low intensity. That's not very
Yeah.
challenging. But if you can kind of talk, but you can't really sing, or you can't really say too much without kind of feeling a bit difficult, that's more moderate. So
That's the zone to be.
yeah, or higher, or higher.
So for most people, when we say walking is not enough, that's the reason, because you can maintain the conversation. Not everybody, of course. That's why
Yeah.
we see walking. So
Yeah.
we can take walking and make it an amazing exercise. Walk on hills. You can do intervals, high intensity interval walking. A few minutes you walk faster, then you slow down and take a break. Stairs, if that works, you can do stairs. Stairs are very difficult, by the way. We did this the entire time. I almost passed out the first time I did it. I had to.
Yeah.
So it's interesting.
Okay. So in terms of now intense, I should go back.
You want to go back
Yeah, yeah.
and take home points?
Yeah. But then now we're looking at resistance training, trying to get at least around 2 sessions a week. And again, within these sessions, it's going to look different for everyone, because when you look at what 3 sets of 8 to 12 reps look like, maybe, Rad is lifting 100 pounds, I'm lifting only 50. It depends on what your strength is. So you don't have to get discouraged. You want to look at your own progress over time. So you might start with a bit of a lower intensity lifting lighter weights, where you can lift more repetitions before you get tired. And then slowly you're going to increase that weight so that you can't lift it as much. Or in the case of isometrics, maybe if you're even just doing something as simple as pushing against the wall, maybe you're pushing stronger and stronger as you get stronger.
So isometric is when you're not moving, or you just holding your position.
Yeah.
That's isometric.
Yeah. So progressive overload is the number one thing. You want to do something that's challenging until you get strong enough that it's no longer challenging for you. And then you want to make it a little bit more difficult after that, so it becomes challenging again. And just repeat that cycle.
That's good.
Can you go back to the pyramid for just a second?
Oh, yeah. That's good.
Okay,
Fantastic.
thanks.
So in terms of what specific exercises you can do, that is where things get a little bit trickier in figuring out what works for you, what you will actually enjoy. So there's lots of resources you can turn towards. These are some examples. The one that we love is almost the gold standard is McMaster Pace, because you get to work directly with physiotherapists, get prescribed your exercise program, and get supervised as you do it. So they have a great facility, great community, lots of machines, so they can show you how to do the exercises, and really give you that one-to-one feedback.
You want to talk about cost very quickly?
Yeah, so
Like 2 lines,
cost. Yeah, so there is a cost to Pace. You are working with professionals. The physiotherapy assessment when you initially join the program is $160. You also can get insurance coverage and things like that for that cost. After that, it's more like a gym membership type of payment model. So $50 a month, roughly, and then $20 if you need to park. So it's at McMaster University, and that's where ideally, if you can have the resources to afford it, that you'll be taken care of very well. You'll be in good
Well,
hands.
we don't want to say that this is the only thing you have to do.
Yeah.
In fact, very high-risk patients or some high-risk patients get referred here for this, where they need a lot of support. But you can do things at home. So there's this YouTube channel here, Yes to Next. That's her and her mom there on YouTube. You can put on your setup on your TV. They take through every single workout you can possibly imagine. And they have a cat running around, and that's why I put it here.
Yeah,
And-
the Aquafit as well.
Aquafit. There's also this program from Australia. It's an online 12-week Tai Chi program. Tai Chi is when you hold a position. It's not a dance exactly. It's an exercise. Or
Yeah.
maybe it is a dance. Correct me if I'm wrong. And it's mainly for joint health. So people who have knee pain, osteoarthritis, that prevents exercise.
Yeah.
It's been one of the best ways to reduce pain and improve mobility.
Also great for balance as well.
Yeah. And this other one is Stronger at Home. I'm not sure if she's Canadian. I'm more biased to put Canadian people here. But she also has exercises you can do at
Yeah,
home.
it's a great website. The only main caveat is it's Stronger at Home, but the website doesn't have a T in it for some reason. It's just strongeraHome.com.
Yeah.
But I love that one. The exercises are great, and they give you lots of good feedback and pointers to learn how your form actually is and if you're lifting
Yeah.
properly.
There's also this. So this is a new thing we learned about. It's called Lifestyle RX. It's covered by OHIP. It's 12 weeks online, originally for type 2 diabetics, but any of these conditions you qualify for. I think you need a referral. You might be self-referred. If you Google it, it's online. You can read their website and see if there's something you can do. It's 12 weeks. It's by physicians, by Ontario physicians and Canadian physicians and dietitians. 12-week program. It seems too good to be true, but apparently it is. It's a good resource also. And there's our groups we have here. We're gonna print this out and give it to you in a drive there. Okay. Fantastic. Any questions so far at all before we get to the last chapter? Okay, quick note on psychological tools. So remember back to the pillars of therapy. One was psychological tool, the other one was medications, pharmacotherapy, and bariatric surgery. And then at the top, the roof is diet and exercise. There's this quote we like that if you fall off the wagon, just get back on the wagon. One of the predictors of weight management is people who have that intrinsic motivation, resilience. Some of these psychological tools, they try to improve people's ability to be resilient, to accept negative thoughts and focus on the action as opposed to try to change the thoughts. And this is what typically happens in weight management. You have automatic negative thoughts. Why did I do this? Why did I go for the bag of chips? That torments the mind. And then you have negative emotions about self. It affects your identity. And then eventually you resign, you stop, right? And you say, what's the point? You have this black and white thinking. If I went for this, an extra snack, I might as well, like the week is gone. I'm just gonna eat whatever. And that happens all the time. And we don't want to put self-blame. It's just a process that happens in the mind. And that's why psychology is one of the pillars of therapy. Here's the summary of the antidote. It's called CBT. It's called cognitive behavioral therapy. This is a summarization of it. You first recognize the negative thought. You don't have to try to challenge or change it and say, oh, I shouldn't have it. Whatever the negative thought is. And this applies to many other things too, right? It's not just weight. You label and name it. In fact, it's been shown that when you label negative emotion, the feeling of the negative emotion goes away just by labeling it. And two, you distance yourself from it. The question to ask, you can't do that. Like it's very difficult when you're really in it, you're feeling it's very difficult to do that. But you can ask yourself, what would a friend say if I were to explain the situation to them? What would exactly, what's the self-talk? How's it different than what you would tell me? And lastly, you try to challenge the thought. Just because you have a thought doesn't mean it's true. And that's the key thing. Just because you have a thought doesn't mean it's true. And you can challenge it with evidence. What I mean by evidence is one day in a week, let's say you don't eat very well. I think you think, look at all the things I've done. Average week is good, right? 90% is healthy. It doesn't have to be 100% perfect. In fact, it's better to be 90% healthy as has a healthy 90% diet than 100% because it's flexible, you have fun, and it's sustainable. There's this picture of an example. So this is how distancing works. This is the mind where you have this hurricane flood, you're in it. Distancing is now you're the satellite looking at it from above. It's difficult to do. It takes CBT, takes practice. Some people you can do it self-directed, but bariatric clinics, other clinics with team-based care, they have some of their psychotherapists, psychologists who provide some of this stuff. And it can be, combination with the other tools, it works quite nicely. This is the form we just gave out. Classically, when you're trying to set a goal, and you want to be specific. So when we say, oh, my goal weight is X, it's not specific enough. Or I want to get more exercise, or I want to watch what I eat. Those are very general goals. The more specific it is, the more likely you're going to achieve it. Right? So SMART means specific, measurable, actionable, relevant to you, not just somebody else. Like your doctor told you need to do this, it has to be relevant to you. Hence why the resilience aspect is important, intrinsic motivation. Okay? And timely. So if you say I lost 30 pounds in 30 days, it's too fast, right? Too fast. And this is something we added, is that SMARTO, trademark, what are your obstacles? What's going to stop you from achieving that goal? What's the contingency plan, right? Christmas is around the corner. That's the obstacle. How do I navigate that and not put a lot of pounds on? Even if you do, not a big deal, but think about the obstacles. The other thing is something called habit stacking. But a lot of people, when they're trying to start something new, it's very difficult, intimidating. Try to build a routine. Attach it to something you already do. You want to walk a little bit more. right before dinner every night or right after dinner. You stack one habit to the other, it makes it easier. And this is probably one of the strongest tools, I would say, doing it with others. Having a health buddy, an exercise buddy, even if it's virtual, your spouse, your husband, etc. Or a meeting, community setting. You're here right now, it's an example. But usually that personal one-on-one or one-on-two, we have a buddy, you go to class, that keeps people accountable. This is probably one of those most important tools in the toolbox, I would say, community. These are people to listen to. It's a long list. We'll email the slides out, okay, and it's going to be on YouTube. The reason we put this here is because when you Google anything, try to learn more information, there's a lot of stuff. There's a lot of information. There's no shortage of information. I listen to all this stuff all the time, so I would put together all the evidence-based folks. We're biased towards Canadians. You see a lot of Canadian names here. Dr. Sean Warden is the first author of the Canadian Obesity Guideline. You Google some of these people on YouTube, you can hear them speak and you learn a lot from them. Dr. David Macklin for the psychology of obesity, you can learn a lot from him on YouTube and listen to some of his talks and other people. My Weight What to Know, they also interview experts on weight and they really demystify many things, answer many questions. And you're sponsored by Novo Nordisk. I think that's a problem, but anyhow. And that is it. Fantastic. Any questions at all about anything? Questions, comments, thoughts? Let me also put this slide here. So this is the Google Drive we're talking about. If you scan it, you see this GLP-1 click chart. So if you're starting it for the future, you can keep trying to save it for yourself. It has a click chart for Ozempic, Wegovy, Mounjaro. So you can self-adjust. And it has a summary of one-page PDFs for a variety of tools. So there's a list in there, how to access CBT, for example, Hamilton, other places. Weight loss facts, and we can probably put this slide here too. This other thing, the reason these two PDFs are out here is because these are the most important documents. This is an FAQ handout, answers the most common questions about GLP-1s, weight loss, this, that, the other.